tell you what we have for you guys. We have PLAB 1 clinchers that are really very helpful for all the candidates. Dr. Aisha, tell you what we have for you guys. We have PLAB 1 clinchers that are really very helpful for all the candidates. Dr.
I'm
Aisha,
hearing my voice.
tell you what we have for you guys. We have PLAB 1 clinchers that are really very
Dr.
helpful
Rashid, I'm
for all the
hearing my voice
candidates.
again.
Dr. I.
Dr. Rashid?
Yeah, it is clear now, is it?
Yeah, it's clear. Yeah,
Okay.
now it's clear.
It
Okay.
was just a
So we
preview
have,
on YouTube. All right.
yeah. So we have PLAB 1 clinchers, we have bookshelves, and we have quiz question banks for you guys. And
Okay, we can do a little walkthrough of what we have already. If you can share the screen, I think it is important
later. Yeah.
before we start talking about anything else, we introduce ourselves. So, welcome to this webinar or the teaching session for PLAB 1. We are today going to cover a part of cardiology for PLAB 1. This is one of the regular activity that we do every Friday for the PLAB 1 candidate, and we intend to continue doing that in future. And most welcome to all those who are participating. Those who miss can join us can watch the video on the YouTube and can come and join us in future. We have just a bit of introduction. I'm Dr. Rashid, and we have today Dr. Durre, who is our regular tutor as well as mentor for the PLAB 1 and PLAB 2. PLAB Guide Academy is one of the academy in the UK with a dual campus, one campus in Manchester and one in Lahore in Pakistan. We take the pride of doing many things at a very high pace. Started in 2022, and just by the end of 2024, we are doing many things. We started with just a single PLAB 2 course, but now, since last month, we are regularly doing PLAB 1 as well. Uh, Multiple courses for PLAB 2, but today we are going to focus on, at the moment, on PLAB 1. What we have for the PLAB 1, I just want to quickly show you those who may benefit. Our aim is to bring everything under one single floor for the candidates to make their journey easy and accessible. Okay, so in relation to the PLAB 1, we have multiple courses, including the quiz and question bank and the clinchers, mocks, revision classes. So I'm just going to show what we have in the clinchers and the sessions. Okay, so we have for the PLAB 1, we have PLAB 1 clinchers, PLAB 1 big mock, and we have PLAB 1 ultimate package that offers the course quizzes and the bookshelf. We have in this course what is already enrolled involved included is a quizzes for every all the major classes. Then we have the bookshelf that covers the notes for everything that you need for the PLAB 1 preparation. And also, in addition to that, we have rapid revision card. They are based on the systems, and they can take you through the important ideas and the concepts for the quick revision. They are very healthy, and they can be used very productively for for the quick revision. So this is just an example. There are 120 cards in this, and they can be repeated for all those cards which are hard. They will keep coming, falling in front of you until you are more confident. And they cover nearly all the systems, and we are trying to put more and more, making sure that nothing is missed and everything is available under one single floor. This is an example again. So what you can see in this ECG, make your diagnosis. If you find it hard, it will come again. You just simply click hard. What is the diagnosis? You can turn it and self-assess. If you find that your answer was right, click easy. Uh, Similarly, in this ECG, if you find that it was hard, just click hard. It will come again in front of you. Here we can see subarachnoid hemorrhage and turn it. If there's something else, just click hard. If you are right, then click easy. This is how you can keep repeating, and every single time all the cards that you clicked that you found hard were hard will come back again in the second round. Okay, just a quick one. Then we in the MCQs, the quiz bank. All the questions have explanations provided with them, with the reason and the explanation of the right answer and the wrong answers. And they can be attempted multiple times. Okay, so this is one of the typical example. Now, I just want to pass it on to you, Dr. Dure. Thank you. Thanks for uh, conducting this session and participating. So I will leave this session in your hands.
Guys, can you hear me? Just a
Yes.
quick information. Okay. So we're going to start with the basic structure of the heart, and that's physiology, because we're going to deal and study regarding cardiomyopathies. And for that, we need to know just a bit of the basics. Okay, so Dr. Aisha, are you there? Are you still there? Can you please unmute yourself? Dr. Aisha, because I just wanted to make it a bit interactive, and it's very enjoyable for the attendees. For the other ones, if you do not want to interact, you can just chat, drop a chat. I cannot see you. Just a second. Okay, so I'm just going to tell you about a bit about the structure. So as you know that the heart has four chambers. Okay, this is the right atrium. Dr. Rashid, can you see my arrow, this arrow that I'm pointing?
Yes. Everything is visible. Please carry on.
Okay, so there are four chambers at the heart: right atrium, and then right ventricle, and then there is left atrium and the left ventricle. Okay, so as you can see that this is superior vena cava and inferior vena cava. So these are the largest vessels of the body, and the deoxygenated blood from superior vena cava, like upper part of the body, it enters into the right atrium, and then from inferior vena cava, so the deoxygenated blood from superior vena cava and inferior vena cava, it empties it into the right atrium. Okay, and then from right atrium, it goes into the right ventricle. Okay, but there are important valves in between these ventricles. Okay, so between right atrium and right ventricle, there is an important valve which is known as tricuspid valve, or it's also known as atrioventricular valve. So you need to know about that. Okay, and then between the right ventricle and the left ventricle, there's interventricular septum, and from the left atrium and left ventricle, there is another valve which is known as atrioventricular or bicuspid valve. Okay. And it's also known as the mitral valve. Okay. So the importance of this valve is that this is the only valve. So there are four valves, two semilunar valves and two AV valves. Okay. So the importance of this bicuspid valve is that is this is the only valve which is bicuspid. The other valves, the other three valves are all tricuspid. So there are three cusps. That's why it's called tricuspid. But in the bicuspid valve, there are only two cusps. Okay. So the valve between the left atrium and left ventricle, this bicuspid, or it's also known as mitral valve. Okay. Then there are semilunar valves, which is the valve between the left ventricle and right ventricle. And then this is the pulmonary artery. Okay. So pulmonary artery then goes into the left pulmonary artery, and then it goes into the right pulmonary artery. And as you know, that pulmonary means lungs. So this left pulmonary artery takes that deoxygenated blood into the lungs for further oxygenation, and then goes back into the heart from the left pulmonary vein. So this is the only exception. Heart has the only exception because you know that the veins carry deoxygenated blood and the arteries carry oxygenated blood. But there is one exception, that is in the heart, that the left pulmonary artery and the right pulmonary artery, it carries deoxygenated blood, and the left pulmonary artery carries this deoxygenated blood into the lungs, and then it oxygenates and gets back into the heart through the left pulmonary vein and right pulmonary veins. Okay. So after the oxygenation, these pulmonary veins, they put all the blood into the left atrium. Okay. And from the left atrium, it goes into the left ventricle by this bicuspid or mitral valve. So the two semilunar valves are the aortic valve and the pulmonary valve. So what is the function of these valves? That would be my question. I'm so sorry, I'm unable to unmute, some technical errors. Okay, that's totally okay, Dr. Aisha. So guys, the ones who are attending, there are two attendees, I think, Ishmita and Dr. Aisha. Can you guys tell me,
Oh,
Ridhima?
we got three now. We got Aisha, Rithima, and Sarah. So welcome all
Yeah.
guys again. So we will keep talking to you intermittently, and we'll continue
Mhm.
progressing into the session as well. So
Mhm.
feel free to
So,
pose your question, raise your hand if you have any question. Otherwise, you can keep
okay.
yourself muted. We will be throwing the questions as well to keep it interactive. And in the poll, you can answer A, B, C, D, E according to the options.
Okay. So, Dr. Ridhima, Dr. Sara, Dr. Aisha, can anyone tell me what is the function of these valves? Why are these valves present? Anyone? They can just quickly unmute themselves and they can answer to make it more interactive. You can just, what is the function of these valves?
I can try to answer.
Okay.
Yeah. So my thoughts are that these valves prevent the backflow of the blood, isn't it? Yeah, that's
Exactly.
very simple. Okay,
Yeah.
let's. So I think so. What will happen is, Dr. Dore, my feeling is, let me just share my ideas.
Mm-hmm.
Just looking on your picture. So if there is
Mm-hmm.
any obstruction in the inferior vena cava, the
Mm-hmm.
blood flow to the heart will reduce, and
Mm-hmm.
there may be the raised JVP in that case because of the pooling of the blood as well. If there is um, any obstruction towards in the flow, and
Mm-hmm.
secondly, if there is any backflow, that can cause a regurgitation and can cause a murmurs. That's what I'm thinking of, isn't it?
Yeah, exactly. And then raise JVP, there's very important question, cardiac tamponade, and you must be knowing of the Beck's triad. So that, of course, we will go through the details of it in the MCQs. Okay. So just a second. Okay. So as you know that there are three layers of the heart: pericardium, myocardium, and endocardium. So pericardium, as you know, that this is the outer covering of the heart, and it has two layers. Then there's a visceral part of the pericardium, then there's a parietal part of the pericardium. Visceral part is facing towards the heart, and parietal is the outer layer of the pericardium. And then there is myocardium, which is known as muscle of the heart. So we are going to discuss the anomalies of the myocardium today, okay? Which is actually the muscle. Okay. So as you know from the name, cardiomyopathies, okay? So we're just going to deal with it, and there are three names in it in itself. Cardio means heart, myo means muscle, and pathies means pathologies of the heart muscle itself. So you know that the definition, you can just tell the definition by its name itself. Okay. So there are other types as well, but they're very less common. So these are the most common and most important types. So there are three actually. Number one is dilated cardiomyopathy. Then number two is hypertrophic cardiomyopathy. And the number three, third type is restrictive cardiomyopathy. And then this is intermixed with, and some of the features, clinical features and presentations is mixed with constrictive pericarditis. And I'm going to tell you how you can differentiate restrictive cardiomyopathy from the presentation of constrictive pericarditis in the end. Okay, so dilated cardiomyopathy and hypertrophic cardiomyopathy, this is totally opposite. So these both of these things, both of these terms, both of these conditions are totally opposite from each other. So first of all, what happens in dilated cardiomyopathy is that there is global hypokinesia. Okay, so which means that the muscles, they just become dilated in the left
That's really
atrium.
interesting picture. I really like it. So I
Yeah,
like the idea. Okay, thank
yeah.
you.
So it's actually there is, as you can see, that there is ballooning of
Excellent.
the left atrium and sorry, left ventricle and right ventricle. So there is, it's globally hypokinetic. So there will be no contraction. Okay, less contraction. So in the heart, it's the contractility issue will be there because it's globally hypokinetic. Okay, so there is ballooning, as you can see. And in the
I think you're talking
hypertrophic,
about the heart failure, isn't it?
yeah, but in dilated cardiomyopathy, there is ballooning and there is global hypokinesia,
Mhm.
and there will be less contractility. So
Which
it's
means
also
that there
known
is a
as
heart failure.
systolic failure. Exactly. So there will be a systolic failure. Okay, in dilated cardiomyopathy, as you can see, that there is thinning of the ventricles. As you can see that these edges, they're thinned out, so there will be less of the contraction. And
There is a
as you
lot of
know,
blood pooled inside. I can
yeah,
see.
yeah. So there is less contraction. So there is systolic failure. Okay. So in MCQs, you know that whenever there will be systolic failure, it could be in dilated cardiomyopathy because there is less contraction, global hypokinesia. Apart from that, in hypertrophic cardiomyopathy, there will be hyperkinesia. Okay, so there will be more contraction, powerful contraction, and there is no time for relaxation. So the heart is not getting any relaxation. So diastolic failure. Okay, because the heart needs time to relax so that there is more pooling of the blood, so that it can, make a good venous return for good
Okay, just
venous.
looking on, Dr. Dore, just looking on
Mm,
those pictures, I can get an idea talking about the dilated cardiomyopathy. I can see the
mm,
room inside the ventricles is quite big. There is a lot
mhm,
of blood collected, can be collected
mhm,
inside. And just thinking about the symptoms that it can give, I believe that the patient would get, because there is a cardiomegaly,
Yeah.
heart is ballooned out, the patient would find difficult to lie flat. They will come with the shortness breath and difficulty in
Yeah.
breathing,
Yeah. Yeah.
typical symptoms. And because the heart is not pumping enough, they will have pedal edema and the ankle swelling and leg swellings and stuff. Um,
Excellent.
Contrary to that, in hypertrophic cardiomyopathy, I can see the room for the blood is very small in the LV and
Mm.
RV. um, there will be less amount of the blood which is inside, and I can see the muscles are quite thick. So, which is why
Yeah.
I think it is called hypertrophic cardiomyopathy, because the muscles are quite hypertrophied, isn't it?
Yeah. Yeah. Yeah.
Okay.
And
Just correct me if I'm wrong.
no, no, sir. Of course, you're registrar, accident and emergency. You cannot be wrong in this. I think. Okay, so hypertrophic cardiomyopathy is so these muscles they're hypertrophied. Okay, so as Dr. Rashid told. Okay, so there is one more very interesting thing that this is mostly in young people. Okay, this hypertrophic cardiomyopathy, and it's I mean, the most common cause of young death. That is hypertrophic cardiomyopathy, and the
Yeah,
cause.
so there's a condition called HOCM, hypertrophic obstructive cardiomyopathy. That is one of the common reason for the sudden death, sudden cardiac
Yeah,
death. It
yeah,
runs in the family, I know that. So what you can see in the typical scenarios that the patient, young patient, died suddenly from the cardiac problem, and there's a family history as well. So if there is any family history in a young patient, most of the time there is a HOCM, HOCM, hypertrophic obstructive cardiomyopathy.
yeah. So yes, as Dr. Rashid said that it is familial. So according to the text, it is 100% genetic. Okay, so the cause is 100% genetic, mostly. Okay, and 50% of the patients will be familial, and 50% will be sporadic. Now, what is the difference between sporadic and familial? What is the meaning of sporadic and familial? So familial is that you will get in MCQs, you will get the family history. Okay, so there will be a family history. But what happens in the case of sporadic, that there will be new onset. Okay, so there is no family history, but because it is genetic, and there will be a new complaint of this, the patient will have, it's, I think, sudden onset, and there will be new onset of these symptoms. That's what sporadic means. Okay, and as that Dr. Rashid has told, the symptoms of it itself. Okay, so as you can see clearly that there is ballooning. Okay, so in echocardiogram also, there will be distinct features and distinct findings. In the dilated cardiomyopathy, you will see that the ventricles, they're ballooned out, okay, as you can clearly see in the picture. And in the hypertrophic cardiomyopathy, there will be banana shaped, okay, or that's what we call in the echocardiogram findings. Am I right, Dr. Rashid?
Yeah, I think
What do
so.
you guys? Yeah, yeah, yeah. So banana shape, there will be a banana shaped for hypertrophic cardio. Okay, so now this is the difference between hypertrophic cardiomyopathy according to the echo findings. Now I'm going to tell you the what findings you will get in the echocardiography. Okay, so in the hypertrophic cardiomyopathy, you will get the banana shape. So there will be uh, problems in the septum. Okay, so septal asymmetry. You will find septal asymmetry in the hypertrophic cardiomyopathy. But in the restrictive cardiomyopathy, as you can see, that it's also there is not so much of hypertrophy, but there is restriction. So contractility issues will be there in hypertrophic and restrictive. Okay, both of these types, they will have contractility issue, but in hypertrophic you will see that there is significant hypertrophy of these ventricles. I hope you guys can understand. Yeah. So Dr. Aisha has told the answer, preventing backflow. Okay. So I was just checking the chats. I thought you guys have question. Okay. So in restrictive cardiomyopathy, there is more of amyloid depositions. There are more, the causes could be depositions. So could be amyloidosis, could be sarcoidosis, could be hemochromatosis. Okay. So these iron deposits, and these deposits in these ventricles and these septums, they are causing stiffening and contractility issues. So there is more and more
There is a
contraction.
restriction of the movements, isn't it? So if the
Exactly.
mobility of the muscles is restricted, they will be flapping less
Yeah.
frequently, with
Yeah.
less
Yeah.
force.
Yeah.
So when the
Yeah.
muscles are rigid, they will be slow in pumping. The amount of the blood that will come out of the ventricle will be less as well. So will
Mm,
give the symptoms to the patient. It can be caused by multiple reasons why the muscles can be constricted, why the muscles could be stiff, and one of
mhm.
them Dr. Dure has just mentioned about is
Amyloidosis,
blood.
sarcoidosis, could be hemochromatosis, iron deposits. All these deposits, they are involved in this restrictive
Yeah,
cardiomyopathy. Okay.
just think of if you add anything extra in the material that makes the muscles purely the
Yeah.
cardiac muscles are made of the proteins, but if you add something additional, it will make it more rigid,
And more stiff, less
more stiff
contractile.
and yeah.
Yeah, yeah, yeah. So in the echocardiogram, you can see that there won't be any banana shape because there is no asymmetry. Okay, so there won't be any such asymmetry. So the features, they mix out with constrictive pericarditis. So Dr. Asha, do you know what is the difference between constrictive pericarditis and restrictive cardiomyopathy?
Uh, in constrictive, what I feel is actually there is no problem, there is no intrinsic problem within the muscles. Actually there is a constriction from outside, like in the cardiac tamponade. It could be because of the pericarditis. A lot of fluid is accumulated outside the pericardium, outside the myocardium, and it is
Hmm.
causing the constriction, and that does not leave enough space for the heart, and it just pushes the heart cardiac muscles inwards, so that
Hmm.
there is no much room for the heart to relax. That is what I'm feeling. So
Yeah.
I'm thinking in that case the patient would get swelling all over, including the face and the legs and everything,
Yeah.
raised
So
heavy.
symptoms, clinical symptoms will be the same. It will be, there will be dyspnea, leg swelling, everything will be the same, but only you can differentiate from the echocardiography and ECG findings. So as you know that in constrictive pericarditis, okay, so one thing, that in constrictive pericarditis is much um, more treatable and has good prognosis, but restrictive cardiomyopathy has very bad prognosis. In constrictive pericarditis, you know that you can just do the pericardiectomy because it's chronic. You do the pericardiectomy and it's resolved, good prognosis. But in restrictive
Yeah,
cardiomyopathy,
we
you
can
can.
do pericardiocentesis as well. Just aspirate the
Yeah.
fluid outside. Yeah.
Yeah. Yeah.
It can be because of the multiple reasons, including pericarditis and the inflammatory conditions of the heart muscles. It is just extra fluid, as in the joint aspiration. If there's any joint swellings and if there's a lot of fluid collected, we simply aspirate, then the joints are easy to move. So similar thing happens in that, in the constrictive one, in the constrictive one, because there is a pressure from outside, the fluid is collected, we aspirate the fluid, then the heart muscles will be relaxed and easy to start pumping properly. Whereas in restrictive cardiomyopathy, because there is a problem within the muscles, you cannot take that out, you cannot remove the amyloids. What you
Mhm.
can do is, if there's any systemic condition that increases, that causes any deposits, that you can treat with the medication. That's the only thing, you will have to give them systemic medications. Say for example, if there's any I really don't know if there's any condition that increases the fat depositions within the muscle. So in that case, I'm thinking if we take lipid lowering agents, that will reduce the amount of the fat within the muscles. But
Yeah.
ideally,
That can deal with the symptoms, but cannot remove the cause. Okay.
yeah.
We can, yeah. So we can make the patient symptomatic better, but you cannot remove the cause. Okay. So Dr. Aisha Chaudhary has this question. If hypertrophic obstructive cardiomyopathy is hypertrophic, how would we choose other option in MCQs? Please clarify if there is any clear stem outlook.
If HOCM is hypertrophic, how
Hmm.
would we choose the option in MCQ? Please clarify.
Mhm.
Yes, HOCM is a hypertrophic obstructive cardiomyopathy. Um, how would we choose?
So she's asking how this patient will present probably in MCQs, how we'll get these MCQs.
So in this, usually that patient present with sudden symptoms. Uh, the typical question that you get in your exam is that someone died from suddenly without any previous no past medical history. Most of the time, the hokum, the patients usually die around 30s. Okay, the question that they want to ask is what should be the next step. They want the options would be perform autopsy. Yes, that's one of the option. If autopsy is one, you can do that on that patient. But many of the time they do ask what will be the further management process, or what is the most suitable thing to do. And one of the option would be um, to review their close family members and perform the cardiac monitoring and echocardiogram. So you need to do that, because the one that who has passed away, who has died, you cannot reverse that, but you can
Mm.
still prevent the sudden deaths in the other family members. This is
Yeah,
normally how they ask the questions.
yeah, exactly. So, and you know that
Anyone, any family member, any family where there is a history of sudden cardiac death, all the family members, the first degree relatives should get the echocardiogram and they should be referred to the cardiologist.
yes, yes. So, young patient, sudden death or syncopal attack after vigorous exercise, sudden death cause could be hypertrophic cardiomyopathy. Okay, so just a second, I'm going to move the slides. Okay, so as you can see that in dilated cardiomyopathy, uh, this is normal heart, which is normal, as you can see that they're normal sized ventricles, there is no ballooning, no hypertrophy, nothing. So of course, in dilated cardiomyopathy, there is no hypertrophy. In fact, there is thinning. So you have no difficulty in differentiating between dilated cardiomyopathy and hypertrophic. It's totally opposite. Okay, global hypokinesia, there is no hypertrophy, hypokinetic, so systolic failure. Okay, because in unable to contract. Okay, so ventricular
Yeah, all the
dilatation.
ventricles, all the chambers are dilated. And this
Yeah.
happens, why this happens most of the time, it is
Mhm.
because it happens is one of the distant complication of myocardial infarction, because the muscles are now weak and they are loose, okay, they dilate.
Mhm.
They cannot tolerate the pressure of the blood within the ventricles and the atrium. So that's why they cause a dilated cardiomyopathy, and the patient would present with the typical symptoms of difficulty in breathing, um, unable to lie flat, swelling of the ankles, shortness of breath, and those kind of typical PND and
Okay,
ortho.
so there is very important thing regarding cardiomyopathy. I was just going through the MRCP notes. So there are four things that should not be included in cardiomyopathy. So every cause is included in cardiomyopathy apart from these four things. So that four things are: number one, blood pressure, like hypertension is not involved in the causes, and valvular heart disease, congenital heart disease, and inflammation, they say. I don't know, Dr. Rashid, what do you say? Because
What
it
do you
was
mean?
written that it
What do
was
you mean?
written that these will not be the causes of cardiomyopathies because these
Yes,
are
of
all
course.
extrinsic factors.
As I
Hmm.
mentioned, most of the common causes which lead to the dilated cardiomyopathy
Hmm.
is the commonest one is a myocardial infarction because the muscles are now weak, the blood
Hmm.
supply has gone
Hmm.
weak, and the
Hmm.
muscles are weak. Okay,
Hmm.
so
Hmm.
that's a typical heart
But why
failure.
not hypertension? Why have they excluded
Okay,
hypertension from the causes?
hypertension, um, regurgitations,
Yeah,
stenosis.
regurgitation and
Yeah,
congenital heart diseases. Why have
yes,
they excluded that?
they are excluded because they cause increased pressure.
Hmm.
When they increase, now if you take me back to the picture that you showed in the beginning, okay, this one. So what happens here? You can see. Let me just. I don't know if I could. Yeah. So in this muscle, you see, because of the obstruction to the flow, the muscles are thick. Why the muscles are thick? Because they are spending more energy. If you go to the gym,
Hmm.
okay, every day the muscles will become thick. Okay,
Hmm. Hmm.
they become more bulky. This is what is happening because in high blood pressure or the hypertension, or in case of regurgitations, congenital heart diseases, there is increased pressure. The heart has to pump against the high pressure. That's
Hmm.
why it leads to the muscle hypertrophy. The muscles
Hmm.
become thick because
Hmm.
they're dealing with the high pressure. Whereas
Hmm.
it is not the intrinsic problem of the muscles. They have high resistance. They are pumping more against the high resistance. So
Yeah,
the
yeah,
muscles of the heart become thick, whereas in the dilated cardiomyopathy, the muscles become weak, and
yeah.
the length of the muscle fibers becomes long. Okay,
Hmm.
so that's
So there
why.
is intrinsic problem. It's not extrinsic. That's
Yeah,
why we
it
have
is
to
not.
fix
It is not extrinsic.
it. Okay, okay, okay. That makes sense.
Yeah,
Okay.
if there's a high blood pressure, now you imagine the heart has to pump against the high blood pressure.
Hmm.
Okay, so there is a higher force against that. So against the resistance, there is a higher resistance. When the heart has to spend more energy, the muscles are working more. When they work more, as if you go to the gym, if you start working, um, the muscles will become bulky. That is happening in the hypertrophic cardiomyopathy. So
Hypertrophy.
which is why any condition that increases the resistance to the blood flow outside the heart will cause hypertrophic cardiomyopathy. Any
Yeah.
condition that causes reduced pressure resistance will cause a dilated cardiomyopathy.
Dilated cardiomyopathy. Much more clear now. Okay, so these are the diagnostic findings that in the heart sounds you will get an S3 heart sound, ECG will be abnormal. There are no specific findings for the dilated cardiomyopathy in the ECG, but of course in the echocardiography, as I mentioned before, that clearly differentiate, you can clearly differentiate it from the other anomalies because there will be ventricular dilatation, there will be ballooning, and there will be low ejection fraction. Okay, so the causes could be myocarditis, trigger gas disease, thiamine deficiency, or alcohol or cocaine abuse. Okay. And then how are you going to treat it medically? You can give the patients beta blockers, ACE inhibitors, diuretics, and dietary modifications by restricting their sodium intake. Okay. So these beta blockers, they actually decrease the remodeling of the heart. This is hypertrophic cardiomyopathy. Again, this picture clearly. Why we are showing these lots of pictures and discussing, because these pictures will will stick to your mind, and you will never ever forget the MCQ whenever you will encounter. uh, just a second. Mhm.
That's really good
Okay,
picture.
yeah, yeah, yeah. Mm. Enlargement of the heart muscles, as you can see that the interventricular septum and the septal, especially for the left ventricle, because you know that left ventricle has to pump more efficiently, because it has to take all the blood to the aorta, isn't it, Dr. Rashad? So
Yeah.
the left ventricle has to pump more effectively, and there needs to be more power, because it has to pump the whole of the blood from the lung to the left ventricle to the aorta. That is why, as you can see, that Dr. Rashad has given a very good example of the gym, because if you're using more and more muscles in the gym, they will get hypertrophied like gymnasts. Okay, so there's more and more contraction, so there's more and more uh, hypertrophy of these muscles, so there is no time to relax, so there is no time of the venous return to come back. And okay, we are also going to do the MCQs afterwards. Just a second. Okay, so this is the last slide, restrictive cardiomyopathies. Okay, as you can see that the causes, as I said, as I have told already, that there are more and more deposits in the restrictive cardiomyopathies. Could be amyloid deposits, could be sarcoid, okay, granulomas, hemochromatosis, iron deposits, scleroderma, in CREST syndrome, you might get these findings, okay, carcinoid heart disease, glycogen storage. So lots and lots of deposits, iron overload, metastatic malignancy. If there is any metastatic disease, so could be deposits in the heart itself as well. Okay, so initially, if the onset is less than 30 years of age, there won't be any symptoms. Okay, but if the presentation is in elderly, like over 65 years of age, there will be exercise intolerance, could be dyspnea, fatigue, yeah, symptoms of as you can see, the pedal edema, there'll be more and more pedal edema. So how are you going to treat it? By medications, could be surgical, medical tree management and surgical management. If the symptoms are less, then of course medically you will manage loop diuretics and beta blockers and all that, rhythm control, antiarrhythmic agents you can give, and or you can go for pacemaker. And at the end, if it's totally bad, I mean, bad prognosis, bad condition, heart transplant. Okay, so Dr. Rashid, can you take us to MCQs if you like, or should I open my subscription?
You, you can whatever you want.
I need to. Uh, okay. Can you see? Can you guys see my screen?
Yes, we
Lab.
can.
So guys, the ones who are attending, it's a really cheap subscription and very informative. Just 10 pounds, Dr. Rashid, is
No,
it?
no, no. It is £8 a month, or
Ah,
um, I think it's 25 or 40, £25 for 6 months, and
yeah.
the other amazing thing that we are offering is extension on the subscription to match the exam. So, and pay once only. So if you have enrolled once, say for example you couldn't take the exam, just we will extend it for the next attempt as well.
As there are many very important and very nice tables in these subscription. As you can see, these are the clinchers. Okay, so you can see this table, really nice table, dilated cardiomyopathy, hypertrophic, restrictive, and we have just discussed everything. Common causes, these are the common causes. You will get these clinchers are made because considering the fact that important knowledge that you need to retain for your MCQs. Okay,
Okay,
so dilated.
that's actually very good one. Yeah. So cardiomyopathy's main feature, common causes. Okay,
Yeah.
that gives a very good comparison. So
Mm-hmm.
in the DCM, dilated cardiomyopathy, we get the main features are the weak heart and enlarged heart.
Mm.
Common in alcoholics, viral infection. Key treatment is the ACE inhibitor and beta blockers. Very good, yeah.
Hmm. In
Uh,
hypertrophic, you will get this thickened heart muscle, and the most common cause is genetic mutations, as we've discussed, 100% genetic mutation, autosomal dominant. Always remember that hypertrophic cardiomyopathy will be autosomal dominant. So if there is one defected allele, there will be disease. Okay.
hmm,
So beta blockers, and the treatment is beta blockers, and this is cardiac defibrillator, isn't it?
yeah.
What is ICD, doctor?
ICD is implantable cardiac defibrillator
Defibrillator. Okay.
because
So,
those patients can go into cardiac arrest.
oh, okay, okay. And in restrictive cardiomyopathy, as you know, that because of all these deposits, now you know the other causes as well, that sarcoidosis could be glycogen storage disease, could be metastatic, could be iron deposits, and then you will manage symptomatically. Okay. There is one very important thing as well over here. If you want to just go through the tables, there is another table that I want to show them. Uh, I think this is this is the case study for hypertrophic cardiomyopathy, as you can
Okay,
see.
sure. Yeah, you can
Mhm.
show us. Yeah. Okay, a 25-year-old athlete collapsed during a basketball game.
Mhm.
Echo shows asymmetrical septal hypertrophy and systolic anterior motion of the mitral valve. Okay.
Mhm.
The combination of collapse during exertion and echo findings strongly suggest hypertrophic cardiomyopathy. HCM is a common cause of sudden death in young athletes with
Hmm.
characteristic echocardiographic findings. Okay,
Hmm.
all
So
right. So
as we mentioned that you will get this scenario 25 year, you will first of all, whenever you get any scenario, guys, always see the age. Age of
young
patient is
patient,
very, very important. So young patient and athlete, these are the clinchers. Collapses during a basketball game.
sudden
Okay.
loss of consciousness. Yeah,
Yeah.
sudden loss of
And you will get these echo. They might give you the echocardiogram findings as well, and they will tell you what option, what is the disease, what's happening. And then of course you will select the right option because you had this 1 hour of webinar with us. Mm. Okay. There is another table, really nice table. I just want to show them. Uh, Wait a second. So table of contents. Mm, mm, mm. No.
what are you looking for?
I'm looking for, there is another table for, there's really nice actually. For all these cardiomyopathies in these clinchers, I just wanted to show them that.
Okay.
Uh-huh.
Are you
Okay.
able to search if you go down to the bottom? I think. Uh, no,
Yeah.
no, no, not there. Just bottom of the canvas. Yeah,
Mm-hmm.
there is a search glass. If you
Yeah.
maybe try, I really
Yes, yes,
don't know if
yes.
we can.
Yes, yes. Table for cardiomyopathies.
No, no, it is not showing.
Mhm.
Just right table. Maybe
I'm
something.
just going to write cardiomyopathies and they might show.
Just click that. Yeah. Okay. That's
Mhm.
beautiful. Yeah.
Mhm.
So
Just
there is a page number 74, page number 80.
mhm. This is the table. No, we've already discussed comparison. Yeah, this was the one. See, so this is so much easier for you guys. I mean, this is beautiful, beautiful. I'm state of the art subscription. Like you just need to search the disease and you will get these tables. And these are really important and really nice tables. You can, guys, you can see that there is ECG finding here, echo finding, risk of, and there are multiple diseases and everything is
Is
very
it
well
possible to
explained.
magnify it, please?
Yeah, of course. Guys, can you see now? Okay, so we have, uh, okay. So ventricle morphology, this is the table, okay? So in restrictive cardiomyopathy, you will get this small sign as well. It might come in MCQs, okay? So this small sign is actually when there is a paradoxical increase in JVP during inspiration. This is what a small sign is. Paradoxical rise in JVP. So there will be S3 characteristic findings. What are the characteristic findings? S3 gallop, systolic murmur. In the hypertrophic restrictive, you will get this a small sign. Okay. And there are ECG findings as well written over here, echo findings as well written over here. And okay, now we're just going to go in. We're just going to solve the MCQs now. Dr. Rashid, should we start solving the MCQs, if you allow?
Yeah, yeah, please carry on.
Mm-hmm. PLAB 1 Ultimate Package. Mm, quizzes. Yeah. Okay. So now we are going to start these MCQs. A 68-year-old woman with a history of rheumatic fever presents with progressive exertional dyspnea, fatigue, and orthopnea. On cardiac auscultation, the doctor hears a loud S1 heart sound and an opening snap, followed by a low-pitched diastolic rumbling murmur. Which valvular abnormality is most consistent with these findings? Okay, Dr. Rashid, do you know the answer?
Uh,
Anyone wants to? Sarah Khan is here.
68, with a history of rheumatic fever presents. No, I really don't know. So there is opening snap,
Mm,
a low pitch
the,
tire. Mm-hmm.
Dr. Sarah, you're there with us. Do you want to give the answer before we choose the answer? Dr. Sarah.
Okay, I will do the poll here.
Mhm.
Okay.
Are you doing that?
I'm just
Diastolic murmur. So, mitral valve is more involved in the rheumatic fever. Low pitched diastolic murmur. Oh, nice, nice. Hosts and panelists cannot vote. And you guys, the ones who are attendees, they can. Okay, Dr. Saad, can you choose the answer if you're there with us? Because I can see someone from the attendees. Dr. Saad is also here. I think just let's just go with
Yeah, carry
mitral
on, please.
stenosis or MR. Okay, MR. There was a whole way of learning diastolic AR. Okay, no, it's wrong. So the answer is could be mitral. What is the answer? The combination of exertional dyspnea, fatigue, orthopnea, loud S1 opening snap, and diastolic rumble at the apex is my MS. Oh, so I was sure that there could be mitral valve. Mitral is involved in rheumatic. So either it was stenosis or it was regurgitation. So it was stenosis, MS. So the murmur of MS would be diastolic rumbling murmur at the apex. Okay. Loud S1, opening snap, and diastolic rumble. These are the clinchers for mitral stenosis. And why other options weren't right? Because tricuspid stenosis, similar findings to MS, but the murmur is heard best at the left lower sternal, increase with inspiration, presents with early diastolic rumble. AS crescendo, decrescendo, systolic murmur, radiating. Okay, so if you read these clinchers and read why other options are incorrect, you might be able to solve the other MCQs because they're more or less regarding the same topic. Sometimes you might be able to answer the others as well. Okay, there is another very important MCQ. A 70-year-old woman presents with chest pain, SOB, and unilateral leg swelling. What is the most likely diagnosis? Okay, Dr. Rashid, oh, we got the poll answers as well. Okay, so pulmonary embolism with DVT, unilateral leg swelling, heart failure, lymph. I think it's PE. What do you say, Dr. Rashid? What's your answer? Have you read this scenario? Are you with us?
Yeah. Chest pain, shortness of breath, unilateral leg pain, leg swelling, most likely.
Mhm.
With the DVT, ACS, heart failure.
Lymphedema. So I think it's because there's SOB, chest
Yeah,
pain, it's
that's
PE with
possible.
DVT.
Yeah, that's right.
Mhm. Yeah, so we got the answer right. Yay. Okay. So chest pain, shortness of breath, unilateral leg swelling. Because so the differential could be heart failure, but in heart failure, there will be bilateral, isn't it, Dr. Rashid?
Yeah.
Yeah, so in heart failure can cause dyspnea and leg edema, but it is less likely to present with unilateral leg swelling and acute chest pain. So it will be mostly bilateral. Okay. In cellulitis, it's a skin infection that can cause localized redness, warmth, and swelling. So there was no redness, there was no warmth. Okay. And in fact, there was chest pain and shortness, and cellulitis will never cause chest pain unless and until it goes to the level of septicemia. So, lymphedema is a chronic condition characterized by swelling in the affected limb due to impaired lymphatic drainage, less likely to present acutely with chest pain and shortness of breath. ACS can cause chest pain and SOB. It is not typically
Let's
associated
move
with.
forward. I think the screen is quite visible. They can read. Um,
Mm, okay. 55-year-old man presents with chest pain. Just a second. Okay. I cannot read because of this poll now. Okay, a 55-year-old man presents with chest pain radiating to his left arm and jaw for the past 2 hours. ST elevation in lead 2-3 AVF, 2-3 AVF. Okay. What is the next best step in the management? Nitrates and send home? No, no, no. Perform cabbage? No. Thrombolytics? Administer aspirin and perform primary PCI. I think they should do primary PCI, isn't it? Because the presentation time is less. Or we can give thrombolytics as well, but primary PCI should be the option. What
That's
do you
right.
think?
That's right. I agree.
Yeah, yeah. This is correct because immediate revascularization with primary PCI along with aspirin, because this is the treatment of choice. But in Pakistan, because we do not have these facilities, so in hospitals we do opt for thrombolytics first, and then we go for primary PCI. But I think the best option for the patients who are presenting less than 12 hours or within 12 hours, uh, primary PCI is the choice. Okay. There is another participant. Wait. Q&As, answers. Okay. 40-year-old man presents with sharp chest pain that worsens with inspiration, improve with sitting up. Okay. He has a recent viral that is pericardial friction rub, acute pericarditis. What do you think, Dr. Rashid?
Agreed.
Mhm. Yeah, let's go to the other one. A 55-year-old woman with a history of hypertension presents for a routine checkup. BP is 150 by 95 despite being on amlodipine. What is the next best step? Okay, amlodipine. So calcium channel blocker she's already taking. She is 55. So we can add on ACE. Increase the dose. Switch to beta blocker. Add a thiazide diuretic. Amlodipine. I think
You're
should
gonna
we
teach me this.
increase? Okay, so less than 55, we give ACE inhibitor. Okay, and then more than 55 years, we give calcium channel blocker. So I think the next step should be to increase the dose, and then we go for additives. We then add ACE inhibitor. Then the third line, we go for diuretics. I don't know. I'm not sure. Let's see. Oh, that's wrong. Hmm. In the scenario of a 55-year-old woman with hypertension whose blood pressure remains elevated despite treatment with amlodipine, adding an ACE inhibitor. Okay, okay, okay. Okay. So yeah, as I said that ACE inhibitor we add, but why not first increase the dose? Why do not we opt for increasing the dose before adding? Dr. Rashid, do you have an answer to this question?
Um, I think that that's a protocol. If the patient is already on and there is no improvement, uh,
Mm-hmm.
instead of increasing constantly, just show me the question again, please.
Mm-hmm. Because I remember that, yes, we do add second line drug is ACE. Less than 55, we first of all start with ACE and then add calcium channel. More than 55 years, we give calcium channel first line, then we add ACE, the second step. But I was confused between the dose. I thought that first of all, we should increase the dose and then we go for adding another drug. But they say that we go on to add on the other
I
drug.
think we just need to follow the protocol. There must be
Mm.
some reason. Um,
Okay,
okay,
let's just.
particularly agents, mm, particularly in patients with a comorbid conditions like diabetes and CKD, which often coexist with hypertension. ACE, in- ACE, in- ACE inhibitors are effective antihypertensive and are particularly beneficial in patients with the hypertension, certain comorbid. Okay.
Hmm.
Dr. Saad wants to say something.
You can unmute yourself, Dr. Saad. We're not able to hear you. Just a second. Okay. A 28-year-old woman at 30 weeks gestation presents with new onset hypertension and proteinuria. Okay. So, which of the following antihypertensives considered safe and effective? That is labetalol. Yeah, this is the correct answer. Labetalol is safest in pregnancy. Then in preeclampsia, you go for magnesium sulfate if there are seizures. Okay, a 65-year-old man with a history of smoking and diabetes presents with intermittent claudication. Um, Intermittent claudication and rest pain in his feet. Which of the following investigations is the most appropriate to confirm the diagnosis of PAD? I'm just going to read it again. I think it's Doppler, ABPI. We also do ABPI.
The most appropriate, I would say, it will be the
Confirm
angiography.
CT angio.
It can be CT or MR if this is it has to be angiography, not the ultrasound.
Hmm.
I really don't think.
Could be arterial Doppler because I think it's Doppler. Let's just go for it. Let's see. Hmm. Oh, it's a CT angio. What is the answer?
Yeah, it has to be angiography. Just go to the
No,
bottom.
it says ABPI. I don't know what's the answer. It's ABPI.
Go to the bottom. Go to the bottom. Go to the
Hmm.
bottom. Yeah,
Why
there's
not
no.
CT angio and MR angio? These imaging modalities can provide detailed anatomical information about the arteries, but they're more expensive, they're invasive, and may involve radiation and contrast dye. They're typically reserved for cases where revascularization is being considered or when the diagnosis is unclear based on ABPI. So the first should be ABPI. I was thinking of ABPI, but then I was like, okay, okay.
All right. So
So
you can
Doppler
you can
ultrasound.
you can
Hmm.
star this question as well.
Hmm. Starting, and there's one more thing flag. I need to flag this question as well.
You have not submitted instead, but you just added given the star, but you need to submit it.
Okay, now I've submitted. I want to flag this question. How would I be able to do that?
Just go on this the question number 7. Yeah.
Mm-hmm. And this flag question. Okay, nice. Arterial Doppler ultrasound can directly visualize arterial stenosis and is also used to assess PAD. So, Dr. Rashid, I just want to ask this question that when there are these three options, and for example, if we have done ABPI and we want to opt for revascularization, and we
Yeah.
have these, how are we going to select one of them, like CT angio, there's MR angio, and arterial Doppler? Why
Okay,
not Doppler?
when we are talking about the revascularization, it is important with that we need to identify the exact anatomy because based on that we can decide whether the patient needs a stent or a bypass. So angiogram gives the real good picture and tells you anatomy where the stenosis is, whether there's a beaded appearance, whether there's a long segment or short. Okay,
Hmm.
whereas Doppler is good in showing the flow, but wouldn't tell you the anatomy.
Hmm. Okay, so Doppler is not going to tell about the anatomy. That's what you've said. And what would be the difference between CT angio and MR angio?
MR is a magnetic, uh,
Resonance.
sorry,
Resonance, isn't it?
yeah, magnetic resonance. So CT angiogram can be done quicker,
Mm-hmm.
but it gives exposure to the radiations. So if the patient is coming with acute limb ischemia, the
Hmm.
idea in that ideal situation, the patient should get the CT angiogram, because waiting for the MR will take long, and
Hmm.
it is not readily available. MR
Hmm.
angiogram happens over hours, at least an hour or longer, whereas
Hmm.
CT angiogram can happen within 2 to 3 minutes.
2 to 3 minutes.
Yeah,
Okay, so do they have to give the dye to the patient
yeah.
or inject the dye? Do they
Yeah.
inject the dye first?
Yeah, yeah. It has to be done in both cases, an EO-CT angiogram or MR angiogram. But for the MR, they first need to do a plain MRI, then they have to inject and give another MRI. Post contrast, pre contrast, and post contrast. Similarly, for the CT scan can happen very quickly within a few minutes.
Oh, that's great. 68-year-old man with history of ischemic heart disease presents with worsening dyspnea, orthopnea, bilateral leg swelling on examination, raised JVP, bilateral basal crackles. So this is congestive heart failure. Mhm. What do you think, Dr. Rashid?
Yeah, that's right. That sounds right. That's an easy question, I think.
Yeah, yeah, yeah. Yeah, all the symptoms of heart failure, basal crackles and everything. It's actually a very good question, Bank. I mean, there are difficult, tricky questions, and explanations are really nice. A 60-year-old woman with a history of hypertension and diabetes presents with orthopnea, PND, lower extremity edema, which of the following investigation is most used as severity of heart failure? Hmm. Severity, I think echo cardiac catheterization, ECG checks the cardiac MRI. I think echocardiogram. What do you say, Dr. Rashid? What should be the option? Severity. What is
Um,
the most useful investigation to assess the severity?
yeah, echo is the best one, I think.
Yeah, because I think ejection fraction you'll be able to
Yeah, ECG
count.
wouldn't tell you the heart failure to that
Hmm.
extent.
Yeah. Echocardia is the gold standard for assessing the severity of heart failure. Exactly. So it can measure ejection fraction, as you know, that 55% is the right ejection fraction, assess valvular function, identify structural abnormalities. Yeah. EF, valvular function, diastolic function, chamber size, wall thickness, everything you can tell by echo. Why not the other options? I just want to read that. That is a very good, it's very informative. Just want to give it a quick read. Why not the others? ECG is not going to tell that. Chest X-ray shows signs of pulmonary edema, cardiomegaly, but not detailed information of the cardiac function. Cardiac MRI is a more advanced imaging modality that can provide detailed information about cardiac structure and function. It is not routinely used for initial assessment. Okay, Dr. Rashid, I mean, in which cases we use cardiac MRI? Because I've never heard of this cardiac MRI being used anywhere.
Um, I believe this is not the routine investigation, first of all.
Hmm.
It is
Hmm.
done when there is any structural abnormality, when the other investigations fail, to
Oh,
find out the
like
intrinsic.
probably if there is something very rare, isn't it?
Yeah, so cardiac structure and function, however, it is not okay. Yeah,
Hmm.
this is one of the rare investigation. I've not really heard of it.
Or maybe if we're suspecting something rare anomaly in the cardiac, then we can go for MRI.
Yeah, possibly. All right.
Hmm.
So
55-year-old man.
this is going to be the last question now,
Okay.
and
After that, are we going to do the revision cards?
Um, no, we will just conclude the
Okay.
meeting. Yeah.
Okay, a 55-year-old man with a history of bicuspid aortic valve presents with dyspnea and a diastolic murmur heard best at the left sternal border. What is the most likely diagnosis? Uh,
Bicuspid valve presents
hmm,
with. Okay.
Diastolic murmur,
Hmm.
left sternal border, diastolic.
So it has ruled out the aortic. Essentially, it's mitral. So now we come up
Hmm.
with the whether this is mitral
MS or
stenosis
MR?
or regurgitation. Um, what do you think?
Think it could be MR, bicuspid aortic valve, left sternal. I don't know. I'll go with MR. I
What
actually
can what can cause mitral dyspnea? Just one
this
single symptom they mentioned, and the sign is that it is best heard at the left sternum.
left sternal border,
Hmm?
MR or MS. I think it's MR. I don't know. It's just like um, I was unable to. Okay,
I think
Doctor Saad
it
is
will be
saying
mitral stenosis. Sorry.
I don't know. Okay, let's go for MS then. No,
So
it's what is it? Is it M? No, it's not even MR. Then what is it? Wait. A bicuspid aortic is a congenital heart defect where the aortic valve has two leaflets instead of the normal three. Yes, we know that. Okay. Okay. Bicuspid, aortic valve is tricuspid always, and mitral valve is bicuspid. Because
just
that is
show
the
me the
only
question
valve.
again.
Yeah. A 55 year
Oh,
old.
with the history of, okay, with the history of, it's,
Mm,
it was really tricky question because
yeah.
I simply thought it ruled out the others and it ruled in just mitral. There's a history, means that's a
Mm.
congenital anomaly. All right.
Yeah, bicuspid because aortic valve has to be tricuspid, and the
Yes.
only bicuspid valve is the mitral valve that is
Yeah.
normally bicuspid. Others are
Hmm.
always tricuspid with dyspnea and a diastolic
I
murmur.
would I would give this question five
Five
stars.
star. Yeah, and I'm going to flag this question. It's very tricky and very important. I didn't even see this. Bicuspid aortic valve. See.
I got excited after I read just the word bicuspid.
Mm.
I didn't
It's a
even focus
congenital.
that they are talking
Yeah,
about.
same here. Yeah. A bicuspid aortic valve is a congenital heart defect where the aortic valve has two leaflets instead of normal three. This abnormality predisposes individually to early development of aortic valve disease, most commonly AS or AR. Okay. So common symptom of AR. So what was the answer here?
These clinical features in context with the bicuspid, if you let it settle, yeah,
Hmm.
strongly suggest the diagnosis is aortic regurgitation,
Hmm.
AR. If you go to the bottom, there is the answer. Go to the bottom. Yeah, keep going. Yeah, aortic.
AR. AR.
Hmm.
Aortic regurgitation is the answer.
Okay, what are the guidelines saying?
Hmm.
According to the clinical guidelines and the management, what the diagnosis
You
of
have to, I
aortic
think,
regurgitation.
open it then.
Hmm.
Hmm.
Okay.
Based on characteristic murmur findings and echocardiogram evidence of valve dysfunction, management depends on severity of symptoms and degree of regurgitation.
Hmm.
Okay.
Nice question.
It was a good question. It actually made us more alert, and we were like, we didn't even realize there was like a congenital problem.
Hmm.
Bicuspid, we didn't focus on this bicuspid.
No, I read that bicuspid, but I didn't focus on aortic valve.
Oh, yeah. Same here, same here. I was
Actually,
like,
it has to be bicuspid. Mitral has to be bicuspid.
mitral. Okay, so over to you, Dr. Rashid, if you want to say something.
No, nothing special. I think it was really good, and there was
Dr.
quite a few things.
Hira Rabani is with us and Dr. Sara Khan.
Are they?
Yeah.
All right. Okay. So Dr. Sara had left. I think Hira Rabani just came. Welcome, doctors. You can turn your mics on if you want. Um,
Uh, taking permitted. Dr. Sara is also here.
yeah.
Mm.
So welcome to the sessions.
Okay, so
I think.
they were muted by us because now they're permitted.
Yeah.
Mhm.
Okay. Dr. Rabani and Dr. Khan, anything that you want to say, anything that you want to ask, please feel free to ask us. Um, we are about to actually conclude the session. It will carry on next week, Friday as well. We are planning to start our PLAB TV soon. In the PLAB TV, there will be PLAB 1 and PLAB 2 sessions happening regularly, once a week, not longer than that, broadcasted on the YouTube as well. About our future coming courses, you all know that we have those the current courses which are available for the PLAB 1 ultimate package that comes with the MCQs, quiz bank, and flashcards and reading material, the bookshelf, and we have the recorded videos as well. With the clinchers, we have those rapid revision cards as well as the clinchers. In the clinchers, you get the slides along with the podcast, which are very good warming up podcasts. If you hear that for half an hour, you will get to know about most of the topic.
All right, let's dive into some critical care. It looks like you're getting ready for something big. Maybe the
We're not
PLA.
able to see the
Maybe
screen.
got some great slides
We're
here.
not able
That
to
looks
see
like
the
everything
screen.
from blood gases to
All
shock.
right,
Even
okay.
some real life cases too, just like you'd see in the ER.
Perfect.
Just
So ready to sharpen those critical thinking skills.
Let's do it.
Okay, so picture this. It's Friday night. You're in the ER.
Because you
A mom
are
rushes in with her
sharing.
teenage daughter. The daughter is
No.
disoriented, agitated, and has those really dilated pupils.
And let's say the
Are you
EKG
able to
shows a
see?
prolonged QRS and QT interval.
Oh man, thinking TCA overdose, right?
Right. Those EKG
No.
findings are definitely big red flags.
Yeah, especially with those classic symptoms. Can you remind me though, why are those EKG changes so important?
Well, think about the heart's electrical system. It's like a dance.
All
The
right.
QRS
Okay.
complex is this big, bold move
Okay,
when the ventricles
I have
contract.
stopped the share.
Long QRS means that movement is
Can
slow.
you see
Now
it
you
now?
can,
That can cause some
yeah,
dangerous.
now,
Got it.
yes.
And the QT interval.
That's the pause between beats. When the
Yes,
ventricles
now we can.
set, a prolonged.
Okay. With all those clinchers, there are the podcasts that will take you through just a warming up exercise and can take you through a lot of important concepts to make easy learning.
Okay, ready for a deep dive into ENT.
Always ready for ENT.
You've got a ton of slides here, all about ear infections, hearing issues, that sort of thing.
Perfect timing, actually.
Yeah.
Yeah, getting ready for the PLAB 1.
Oh, right.
Yeah.
Level 1 exam.
Yeah.
So we've got to make sure you're all set for those tricky ENT questions.
Absolutely. Those tiny organs, they cause a lot of trouble, don't they?
They really do.
It's amazing how much they impact our lives.
So where do we start?
Let's jump right in with a common one. Acute otitis media. You know, the classic ear infection.
Ah, good old acute otitis media, a childhood favorite. So, what are we looking for when a kid comes in with a suspected ear infection?
Usual suspects, really.
Okay.
Earache, fever, and they've probably had a cold recently. You know, some sort of upper respiratory infection.
Right. The sniffles.
Exactly. But here's the thing, if the pain suddenly goes away and then there's discharge from the ear,
Uh-oh.
that's a pretty good sign that the eardrum has
That's very good
perforated.
point.
Ouch.
Mm.
And speaking of seeing things, we've got a slide here with some otoscopy images.
Oh, nice.
They show exactly what you're talking about. Red eardrums, some are bulging, some have fluid behind them.
Yeah.
And there are even a few showing perforation and discharge.
It's amazing what you can see with an otoscope, isn't it?
It really is.
So much information packed into that little tool.
So, how do we tackle this?
Yeah.
How do we manage acute otitis media?
Well, first things first, we've got to relieve the pain.
Right.
So paracetamol or ibuprofen are usually our go-to choices.
Okay, makes sense.
Yeah.
What about antibiotics? Are they always necessary?
Not always. We tend to hold off on antibiotics unless the child is really unwell or the symptoms drag on for more than 4 days.
Got it. So we're being cautious with the antibiotics.
Exactly. And even if we do decide to prescribe antibiotics, our first choice is usually amoxicillin for 5 days.
Amoxicillin, the classic.
Yeah.
But I'm looking at our notes here, and there's a mention of some pretty serious complications that can come from acute otitis media.
Yeah, it's important to be aware of those.
Like what?
Well, things like mastoiditis, for example.
Mastoiditis.
That's when the infection spreads to the mastoid bone behind the ear.
Oh, wow.
And that can be a real worry because it can even lead to meningitis in some
I believe that you're
Wow.
enjoying it.
Yes.
Yeah, so understanding the signs and symptoms and those potential complications, it's all crucial for the PLAB1.
Right. It's not just about knowing the basics.
Mastoiditis can cause meningitis.
Okay, so
That's
we've
what I
covered
was in
the
the
ear
information.
infection. But what about something a little more subtle? Our notes mention glue ear or otitis media with effusion.
Ah, glue ear. That's a sneaky one.
What do you mean?
Mm.
Well, it doesn't always present with obvious symptoms.
It's like a silent troublemaker.
You could say that. Imagine a child with fluid building up in their middle ear, causing hearing loss, maybe even speech delays, all stemming from a previous ear infection.
Wow.
And parents might not even notice anything major, just a bit of ear pain every now and then, or a feeling of fullness in the ear.
And we've got a note here about parental smoking being a risk factor.
Absolutely. Exposure to secondhand smoke, it really increases the risk of glue ear.
So that's another important thing to discuss with parents.
Definitely. It's all about educating and empowering parents to make healthy choices for their kids.
Okay, so how do we diagnose glue ear? Back to the otoscope.
You bet. With glue ear, you'll see
Okay, so that's really good, isn't it? When
Yeah.
I start listening those podcasts, it just drives me, make me focus on what they are talking about. That's really interesting. Okay, we have PLAB1 big mocks and we have revision classes, and there is an interesting thing that we have the session coming for the PLAB1 on between 13th of January till 17th of January. That's a 5 days session. There are a couple of candidates who are already enrolled, so we will start on Monday, Tuesday, Wednesday, Thursday, Friday, Sunday. There will be a discussion. So there will be one full mock, the big mock along with this, and we will do the discussion. On Saturday, a new big mock will be added. With every revision course, it will be available on the Saturday after the course, and we will do the discussion on Sundays. So anyone who will be interested, I believe that they will like the idea and they will get the benefit.
When are these going to start? From
It is on 13th of January, starting on 13th of January, and
17th.
yeah, and it is price, it is price only £90.
Really?
In comparison to PLAB, I think their 4 day session is only 4 day session is £130.
Mm.
But It is we go a
But the
couple of times.
subscription to the MCQs and question bank and the bookshelf and clinchers, everything is just for £8, as you said, right?
Yes, that is only for the £8
Only £8,
per month.
which is
But
nothing.
yeah, per month, and £25 um for 6 months.
6 months.
£25 forever. I mean,
Yeah,
till they pass the PLAB one.
yeah. So because usually you prepare for 6 months only, and it's a very good subscription. I really liked it
And you know
also.
the disaster with the other providers is, say for example, your subscription ends 10 days before your exam, and
Yeah.
you will have to pay again. But with us, if they simply tell us that their subscription has expired and they want it extended to match the date, we will do that.
Mm.
Okay, it was really good, healthy session, Dr. Dore. We got a lot to do. Now we have a PLAB 2 session. Then we have post PLAB 1 webinar. So all day very busy. So we'll see you take your break and enjoy your coffee or tea or have a bit of snack. We will see you shortly. Okay.
Okay. So how was the overall session? I enjoyed
I really
studying
love
and
it. I really love it.
the dilated
Yeah.
cardiomyopathies and all that.
You didn't ask me anything about the PLAB TV. I think you will
Oh
ask me
yes,
after.
I really want to know what's that. I heard it like PLAB TB, and I was thinking
No,
that
no, no,
why
PLAB
TB?
TV. Yeah. So
TB, okay,
yeah, PLAB.
nice.
So that's a plan.
Okay, great. What about it?
It will be just doing as we are doing, just talking about different topics and maybe covering important and sensitive cases in the scenarios, especially for PLAB 2, and important topics on PLAB 1 as well.
Great.
Yeah. We're going to
Nice.
start a trial of that one session every week and see if the people are interested, then we will increase the frequency.
Sure, sure.
Yeah.
Thank you so much, Dr. Sara, for being there with us till the end. Uh,
And Dr.
next,
Saad as well, yeah.
yeah, Dr. Saad is also here. I'm not able to see him in the new mother hate labor. Okay, I was unable to join his
Okay,
speaker.
so
Okay,
we're gonna just finish and we'll see you after, we'll meet again after some time.
yeah,
Maybe I think
okay.
45 minutes. All right, thank you.
So nice meeting Dr. Sara and Dr. Rashad again. Okay, take care.
Thanks.